Hello, I'm Dr. Ravi Goel, an ophthalmologist in Cherry Hill, New Jersey, and a volunteer faculty at the Wills Eye Hospital in Philadelphia, Pennsylvania, United States. I'm going to be speaking on my experience with Vision Blue in 2023. My financial disclosures are listed here. Today I'm going to be speaking about 4 clinical cases in which I find Vision Blue to be especially useful. Here you'll see a case that does not require Vision Blue. Here I'm making a capsulorhexis using a bent 30 gauge needle, and I approach the capsulorhexis by having an iris sweep in my left hand and performing the capsulorhexis with the bent 30 gauge needle in my right hand. I come around and I make a complete capsulorhexis, which is about 5 to 5.5 millimeters. Oftentimes I'll take a Utrata instrument to complete the capsulorhexis. There the capsulorhexis has been completed, and I'll take a Utrata to remove the capsular remnant. In this case, I'll be describing arcus senilis, cortical cataract, corneal haze, and white cataracts, and how I find Vision Blue to be useful in these cases. So let's jump right ahead. Here you'll see the first step when I use Vision Blue. I'm injecting Vision Blue into the anterior segment. You'll see in the right side, the lower right side, and the lower left side that the Vision Blue is staining the anterior capsule. In the upper left-hand corner, I'm not satisfied with the Vision Blue staining, so I injected some viscoelastic and now I'm painting the Vision Blue onto the anterior capsule. Once the Vision Blue is adequate, I inject BSS to remove any residual Vision Blue, followed by Viscoat and Provisc. This allows for a very good staining. You'll see here, I'm almost ready to begin my main incision in these cases. And in the lower right-hand corner, you'll see I have a perfect Vision Blue and ready for capsulorhexis technique. And now we are ready. In the next step, I will describe how I perform a capsulorhexis. Here I mentioned I take a bent 30 gauge needle with an iris sweep in my left hand to perform the capsulorhexis. In the case of the white cataract in the lower right hand corner, I perform an initial decompression using a needle, and I removed some milky white cortex. I then use a microrhexis to perform a double rhexis technique. And if you look at the bottom right hand corner, the white cataract, I find it initially valuable to make a very small capsulorhexis. And the Vision Blue is very helpful in this regard because it helps to stabilize and give me a good view and hopefully to help prevent the Argentinian flag sign. Here you'll see in the upper left-hand corner, I'm just completing the capsulorhexis and using the Utrata to remove that capsular remnant. So now let's go back to the case in the lower right-hand corner, which is the white cataract with a very small capsulorhexis. What I then do in this case is I perform bimanual irrigation and aspiration, in which I help to get some of the white milky cortical material removed from the white cataract. This is followed by my main wound incision creation, and then I'm going to inject viscoelastic, in my case Provisc, and then I will perform capsulorhexis extension. I make a small nick in the anterior capsule, and I use these Utrata forceps to make the capsulorhexis larger. I'm still not happy with the size of my capsulorhexis. I prefer it to be 5 to 5.5 millimeters in size, so I make another little nick. And here also, Vision Blue is very helpful because now I can extend the capsulorhexis in this white cataract technique to perform a properly sized capsulorhexis. In the next step during my phacoemulsification, I perform a stop and chop technique. I phaco down the center and I try to create a crack. And you'll notice that the nucleus cracks pretty easily in the lower right hand white cataract as well as in the upper right hand. And here you'll see I've already taken out a heminucleus in the upper right hand corner. In the lower right hand corner, you'll see that the white cataract also, I'm able to perform a stop and chop technique where I'm bringing out the heminuclei easily. You'll see there's a large cortical material remaining in the lower right with the white cataract. In the upper left-hand corner, I'm performing stop and chop technique, but it turns into a bowling situation where it's difficult to get these nuclear pieces out, and I end up with a large epinuclear piece for which irrigation and aspiration will be helpful in the pursuant steps. However, I do like being able to see with the Vision Blue the anterior capsule during each of these steps. Now you'll see IOL insertion. I like to inject the IOL into the anterior segment and let the haptics open up naturally on their own. On the right-hand side, you'll see that I left some cortical material behind because it was especially sticky. I'm trying to remove the cortical material using my irrigation and aspiration instrument. I find that I'm then going to be helpful to use bimanual irrigation and aspiration in the original white cataract. And here you'll see with bimanual irrigation and aspiration, those little remnants are removed. I do the same thing actually in trying to get this little piece out in the lower right hand corner, and then also in the upper right hand corner you'll see I have this small capsular remnant for which bimanual irrigation and aspiration is especially helpful. Once I have inserted the IOL into the capsular bag, you can then see the difference. This is the preoperative view of the 4 cataracts, which had arcus senilis upper left, cortical material upper right, corneal haze, and white cataract. And now you see the postoperative results, in which I have 5 to 5.5 millimeter capsular rexi, and I have centered intraocular lenses. I'd like to point out another technique called radiokeratotomy, or RK, and how helpful Vision Blue has been for me in these cases in which I have RK and cortical material. Here I'm using the Utrata to create the capsular rexus, and then all of a sudden you'll see some patient movement. The patient jerks and goes off, but then I'm still able to use the Utrata to complete the capsular rexus, and the Vision Blue proved to be very helpful in this regard. And now you'll see for the radiokeratotomy, the upper left-hand corner is the preoperative, followed by Vision Blue, post-rexes, and intraocular lens in the capsular bag. Vision Blue has a number of key messages which I have found to be helpful. Our hope is to preserve endothelial cells which are critical to cornea surgery and cataract surgery. I think the Vision Blue helps in this regard. After extensive research and testing, Trypan Blue at 0.06% concentration is shown to help deliver a stable and continuous capsular rexus. Vision Blue, or 0.06 Trypan Blue, is the only FDA and NMPA approved capsular rexus stain. What I find most helpful is that since their launch, Vision Blue has been used in more than 9 million cataract surgeries with no or very few confirmed adverse events. And Vision Blue is provided in an easy-to-use, pre-filled, sterile syringe, which is helpful in many surgical settings. Finally, I'd like to point out the difference between Vision Blue and ICG, indocyanine green. ICG I remember using in the late 90s when I was a resident of ophthalmology in Baltimore, Maryland. And ICG was a wonderful tool in those days. But ICG is an off-label use for cataract surgery, and it's provided as a powder which requires reconstitution and mixing with BSS prior to use. So you can understand the difficulty with finding the right concentration in the clinical settings, whether you're in a hospital or an ambulatory surgery center or many different settings around the world. In addition, ICG has a shelf life of less than 8 hours, and there have been reported cases of TAS, or higher inflammation rates, versus Vision Blue. ICG is also felt to deliver inferior contrast during cataract surgery. Vision Blue is approved in Europe. I'd like to thank you for your time and your attention. The QR codes will take you to my personal blog in which I have links for cataract surgery. Please also feel free to email me or to engage with me on social media for your questions and comments. I look forward to a robust discussion, and I look forward to your questions. Have a wonderful meeting. Thank you.